My interest in peri-implantitis arose, I would say, probably about 6 or 7 years ago. I'm a periodontist, and I received a referral for a peri-implantitis case. And I didn't really know how to treat it because I didn't get trained in school, so I had no idea what was the best way to proceed. I went to the literature. I couldn't find any really clear guidelines or a how-to guide. And I really started my odyssey on one step at a time. And what happened is I sort of developed a reputation for being the go-to person for failing or ailing implants, which isn't necessarily the most rewarding part because you're trying to backtrack. The good news out of this experience was that I learned, and I learned from mistakes. Hopefully I try not to learn too much from my mistakes, from other people's mistakes, but I evolved slowly. And what I'm going to present to you today is a distillation of some literature and some of my experiences in treating ailing and failing implants. Ideally, as dentists, we really want to try and provide the best for our patients, and that's our goal. And for sure that's your goal because you're here to learn and get better at what you do. And most of the times we achieve a very nice result. However, unfortunately, there are some times where we find ourselves with less than optimal outcomes. And the scope of what I'm going to be talking to you about today is definition. So first of all, we want to know what we're talking about. Now, some really straightforward definitions. The most important part is diagnosis. How do you pick up those cases early on? And then move on to treatment, prevention, and discuss very briefly what would an ideal maintenance setup be in your office. So just out of curiosity, from this room, how many of you maintain dental implants in your practices? Okay, so there's a very good number here. I have Jean here in front of me, so I'll pick on you. Have you found the treatment of peri-implantitis in your office to be a very predictable treatment? For the most part. So we're making really progress in trying to understand and treat more predictably this condition. In general, implant mucositis can be defined as a reversible inflammatory condition. It only really is a very superficial inflammation of the tissue on the implant. And you will see a plaque accumulation, you will see some bleeding on probing on the surface. And if that is you on Monday in your office, and when you're doing your examination, you see an implant in this molar location, you will notice that there is some redness of the tissue. So your next step, I mean, if you're a periodontist like me, is to pick up your periodontal probe. And now you want to see whether this inflammation really extends deeper into the attached tissues or whether it only stays in the superficial aspect of those tissues. So I pick up my periodontal probe and I see this is a 10-millimeter probe. I'm about 3 millimeters into the soft tissue. So I have a good understanding that this is not extremely invasive. And obviously, as soon as I remove my probe, the area starts bleeding. So I have now an area of inflammation, and now I have to think, what am I going to do about it? Typically, what we used to tell our patients is you've got to brush better, you've got to floss better. That may work, and it may work well in dentition, but sometimes in the treatment of implant mucositis, we might need to do some additional treatment. So if we look at some studies and the consensus of the 7th European Workshop, what are additional tools that we can use besides dental floss and toothbrush to perhaps address this area? First of all, it's comforting to know that mucositis is a reversible condition, so the treatment that you apply really can work. And the other thing that's interesting to know is obviously that not all of your mucositis cases will progress into peri-implantitis. The problem is that we don't know which ones will and which ones won't. So my recommendation to you today, and I'm urging you today, to really deal with the mucositis cases in a systematic fashion and really address this inflammation that you're seeing. Because you don't know if this patient in a few years will come back and the 3-millimeter probing depth you had today will become a 6-millimeter probing depth tomorrow. So different options that we have in terms of this initial treatment, and again, we're using a Cochrane database systematic review by Grusoven, would be very simple things. We know, for example, that Listerine works well as a mouthwash when compared to placebo. So if the patient has generalized inflammation in their mouths, the use of a Listerine mouthwash can be actually helpful. If you want to go one step up, chlorhexidine works well as well, but here I would recommend that the patient irrigate. You can use a water pick or you can give them a little syringe and irrigate under the tissue. It is way more effective than having your patient rinse. It also will decrease to some extent the degree of discoloration that you get from the chlorhexidine. And the last point would be that ultrasonic instrumentation has been found to be as efficient as mechanical scaling and root planing, so you can use either or, whichever technique works best in your office, to debride the area. Apart from that, let's assume that your patient now comes back and the inflammation hasn't quite resolved. So you're looking at the soft tissues and you still have bleeding on probing, and you're not really sure, despite the patient's best effort to brush and floss and clean with proxy brushes, you still have a little bit of inflammation. There's one more tool that you can use in your armamentarium to address this, and that tool is the use of local antimicrobials or antibiotic agents. Chlorhexidine, except for mouthwash, also comes in a gel preparation. I don't know if you have it here in the US, but it is available, I know, in Europe, South America, and we have it in Canada. You can also use a periochip. Another antibiotic that can be used would be a doxycycline hyclate, known as Atrodox, or a minocycline microspheres. And all of those local antibiotics have been shown, have had really great success in their use in those early implant mucositis cases, even I would say very early peri-implantitis cases, but you have to catch it on early. So those really work well, but not really in advanced cases, as we'll talk about in a minute. So according to studies, different studies, I'm quoting Renvert here, who has done a lot of research in this area. When he compared minocycline to chlorhexidine, he found that minocycline was superior, and that has been my experience as well. I use minocycline, and I'll show you a case in a second, of Atrodox, which is another product that I like, in apposition when I put it in the sulcus. So this is a picture of the packaging of one of the products, and this is a picture of another product that I use quite often in my office. And what you do is you take the cannula of the product and you insert it in the sulcus, extrude it slowly and move it around the whole sulcular area. What I like to do, and that's not recommended from the company, but I have found it successful, is I like to push on the tissue as I'm extruding. So I lock the product inside the sulcus and put a few beads of cyanoacrylate on top. And the reason why I do that is I find many times the sulcular fluid, you get extrusion of the material out, and it really gets out of the sulcus before you have any chance to really get any effect from it. So that product stays in place for about a month. I bring the patient back a month's time, scale and remove any excess material that I have left there, and the majority of the times we get a very, very nice result, and the inflammation goes away. So it's a very nice tool to use in adjunct to any other chemotherapeutic agents you might be using. So apart from, you can see the product is extruded here and it's in place. So this would be my protocol for any implant mucositis cases that I see in my office. Now we're going to come to the more challenging case, which is peri-implantitis. Peri-implantitis is this inflammatory process that affects the deeper surfaces of the tissue, the bone, and you get generalized inflammation and bone loss. And again, here I would urge you, diagnosis is really a critical tool in this, because obviously the fastest you pick it up and the fastest time to treat it, the less damage you have. To bring this into perspective, because this is a topic that I'm very passionate about, I want you to visualize and think of how many implants you're placing in your practice. So let's assume that you're placing 100 implants in your practice. If you look at the studies that have come out of Sweden and Europe, you will see that the incidence and the prevalence of peri-implantitis is 15 to 30%. 15 to 30% out of those 100 implants that you have placed, on average, at one point, 15 of those implants are going to come back with a peri-implantitis problem. The fastest you pick it and the sooner you get a protocol set up in your office to deal with this, the better off you're going to be. It is something that I'm seeing in my practice more and more, to the point where I would tell you that a good third of my practice now is treating peri-implantitis and nailing implants. So really extremely important to be aware of this and to have an idea of how to go about it. So I'm going to require some audience participation now. We're going to go through the parameters of diagnosis. So what are you going to use to diagnose this condition? So I'm just going to open it up. Jean, I'm picking on you again. What would be, if you're having a patient that's coming in for an exam and you have a concern with an implant, what's one of the steps, let's say the first things that you might do to check whether the implant is failing or just ailing?
Whether there's presence of bleeding, purulence.
Excellent. Okay, so Jean says there's presence of bleeding and purulence, and that's very correct. There is one thing that we would start with, and my first point would be also I would check mobility to begin with. So the first thing is you check your mobility. Now, mobility is not really a good indicator of peri-implantitis, because once an implant is mobile, the implant really has failed. So if you have any mobility, it's a done deal. The implant is coming out. The second point that you're going to be looking is a bleeding on probing. Now, bleeding on probing per se is not an indicator, but you're going to use it in aggregation with the other indicators to make your diagnosis. After that, you're going to be looking at increasing probing depths. Now, here's the problem and here's the rub. The way we're placing implants now, when we're going subcrestally or at the osseous crest, our probing depths do tend sometimes to get deeper and deeper because of our placement. So it's not an absolute number that if you have a probing depth that's 5 millimeters, all of a sudden you have peri-implantitis or there is a problem, because that could be the physiologic adaptation of the tissue. So it's extremely important to have good baseline measurements, and I can't overstress this. You're placing your restoration, you're going to take some probing depths, let's say 1 or 2 months after the placement, and you're going to compare those probing depths over a period of time to make sure that they're not increasing. So increasing probing depths are definitely a sign of a problem. And then if you go on from there, the other thing you're looking for is, as Jean mentioned, suppuration, which is obviously very important, and a radiographic examination. Now, your radiographic examination, again, has to be over time. One single radiograph might not necessarily give you the picture, but if you have a series of radiographs and you're seeing consistent bone loss over time, that definitely is a clue that there is a problem. So this is a patient that presented to my office. She was referred to me with a diagnosis of pyogenic granuloma, and I looked at that area and I'm thinking, okay, don't think that quite fits. And of course, being a periodontist, the next thing that I do is I pick up my periodontal probe and I probe the area. And as I probe, this is a 10 millimeter probe, I have a 9 millimeter probing depth there. So the next step would be to take a radiograph, correct. So now I'm taking a radiograph and I am seeing that I have now bone loss around this implant. But I need one more piece of information in order to be able to be sure about what has happened here, and more of a historical fact. So I call up the prosthodontist that placed them and ask for an x-ray of the implants at the time of placement. And as you can see now, I'm seeing a significant change in the bone levels for that patient, and now I can make my diagnosis of peri-implantitis. And obviously, as we'll talk about in a minute, proceed to treatment. Treatment, unfortunately, doesn't always leave you with a very aesthetic result, but many times what we're mostly concerned about is the stability of those tissues and the long-term outcome, and for the patient to be able to keep the restorations in place. So in terms of treatment now, we're going to walk through the different possibilities of treatment and the different options that we have, our armamentarium of different treatment options. The one aspect of treatment that we can talk about for peri-implantitis is a non-surgical treatment. And I can tell you I have tried several times, because I'm a very conservative professional periodontist. I don't like to go into surgery right away, but in this particular case, it really hasn't worked well for me. So non-surgical therapy for peri-implantitis, in my experience, really hasn't been very successful. You can try the mechanical therapy, like we talked about the treatment for implant mucositis. You can try the antimicrobials. You can try systemic antibiotics. If you don't get down there and decontaminate that implant surface really effectively, you're really not going to have a very high long-term success rate. It might work for a month or 2 or 6 months, but the disease will recur and you're going to be back at square one again. And already you're dealing with a patient that's fairly hostile because they've gone through this treatment, they had the impression that this treatment was going to last forever, and now here you are and you're bringing them back for continual office visits. So now sort of some of that frustration is coming your way because you're seeing as the scapegoat, you're caught in the middle. So I would rather recommend to you that you go into a more decisive approach when it comes to peri-implantitis treatment, and that would be the surgical approach. So for surgical approaches, we have I would say probably 3 categories that we'll go over in a second. But the most important part of your surgery, no matter what you do, is to decontaminate that implant surface. You have to try and make that implant surface really pristine. And this really, really is a challenge right now and where we're at, because despite the fact that we have many materials at our disposal, one of the problems that we have is we don't have the information that will give us the best combination of materials to decontaminate that implant surface. So if there is one area in our fields that we really need to work more towards, that would be implant surface decontamination. I have used all of those products. I have used them in sequence. I have used them all together. I have thrown everything at those surfaces that I possibly can. And I don't have a recipe to give you. I work with a microscope. I'm able to really see the surfaces very well. I work under extreme magnification. I can only give you some information that's out in the literature and my personal experience, but nothing here is written in stone, because this is an area that we need future research in. So if we look at some of the systematic reviews that are out there, one of them is by Druska and just published, so it's fresh off the press. It was found that citric acid is a good material to use for the decontamination of the implant surface, because it does remove a biofilm as well as decontaminates it. But mind you, this is in vivo. It's in vivo. So it doesn't really take into account all the blood and the bacteria and saliva and whatever else might be on that surface. So at this point, I would tell you that anything goes. Do your best to really clean the area as well as possible, and do use a combination of these materials in whichever way you seem fit. Once you've decontaminated, you've decontaminated the surface, now the question is, which way are you going to go? Are you going to go into a flap resective kind of surgery? Are you going to look at the regenerative part? Or are you going to put your hands up and say, you know what, there's nothing I can do here, this is really bad, and explant and go ahead and proceed with bone graft and start all over again? So for flap and resective, this is my patient up here. His name is Gary. Gary is an electrician, and he goes up north. And I don't know if any of you have ever been to Canada, but up north is like 50 below. And he works under pretty harsh conditions, and he goes into those different areas and does electrical work. So Gary came into our office. He had periodontal disease, and a colleague in our office extracted the teeth that were very severely periodontally involved and placed immediate implants in that area. And then Gary left. And when Gary leaves, he pretty much leaves for like a year at a time. He's up in those stations, in those remote stations, comes back a year later to have abutment level impressions. And during the time of the abutment level placement, the restorative dentist that was doing that noticed a radiolucency along the threads of this implant. So the concern there was, what's going on? So because we work in an interdisciplinary office, I got called over and said, okay, have a look at this. And I picked up my periodontal probe again, and I just had a look, and sure enough, we have a 6-millimeter pocket on the anterior implant. So at that point, I recommended that we do a flap so we could see better what was going on, and the area now is surgically flat. Now, I'll show you in a second, Gary has very, very thick tissue. So I do make a small differentiation in terms of my treatment. When I have a really thick biotype, I have better blood supply. And sometimes what I'm going to show you works really well for me. So the treatment here for Gary was that we really cleaned and aggressively scraped the implant surface. The defect that you're seeing there is extremely shallow. So we're talking about 1 millimeter intraosseous. Smooth that down, decontaminated the implant, and then proceeded to close the flap, put him on a very, very strict oral hygiene regimen. I think he got tired of me checking his plaque score on a daily basis. The good news for Gary was that we managed to get almost like a soft tissue adaptation into these implant surfaces, and he has now been stable for the last 4 years with 3-millimeter clinical probing depths and no bleeding on probing. Now, if you look, however, radiographically, you'll notice in a second that there is no fill of bone there. So what I think has occurred, if I were able to look at it, is that we've got some kind of adhesion of the soft tissue onto the implant surface that at this point is non-probable and non-inflamed. So Flap surgery or an apically positioned flap sometimes can come in handy. I wouldn't recommend it in patients with an extremely thin biotype because you can run into trouble there. But for patients with a thicker biotype, it can be very, very handy technique. And it has been fairly predictable in my hands in terms of treatment. Your second option is in your surgical armamentarium is to look at regenerative therapy. Now, for regenerative therapy, again, there's a host of materials out there in terms of what you can use. The problem is that, again, we are not extremely predictable in regenerating the whole defect. We can regenerate a portion of the defect, but many times we cannot fill the whole defect. So, again, we're relying on very good disinfection of the implant surface in order to be able to get soft tissue adherence or attachment. This is a case that we did at our university. This is one of our residents there. This patient was financially very constricted, managed to save enough money to put those 2 implants, and lo and behold, about 5 years later, they developed Implantitis. And she was very upset. She came, she's crying. She says, you know, I had put all my money aside. I was told that those implants were going to last for a long period of time. And now we have this issue of bone loss. So even though this is not an ideal case for regenerative because we don't have a trough and we don't have an enclosed defect, the thought was that we were going to try and do some bone grafting there. And because this patient has a very thin biotype, we also, which I don't have here, but you did a connective tissue graft on top. This implant surface was disinfected with antibiotics. We used a laser as well. So again, very aggressive cleaning. This is a bone allograft, a freeze-dried bone allograft that was placed. In fact, I think it's a Dentsply product that we used in this case, and a membrane that was placed on top, and then a connective tissue graft on top of the membrane. And the good news for this person here is that we've had this situation of great stability now for the last couple of years. Reduction of clinical probing depths. They're really being monitored very often with good oral hygiene, but we've managed to be able to stabilize it, and patient is happy, and so are we, because of course, you feel very bad when you see so much distress when they come in. The last, of course, option is explantation, and that's where none of us want to go, but sometimes we don't have a choice. And it's interesting to note that once you explant and you re-implant, your success rate is not going to be as high. So according to 2 studies, and I'm giving you one by Grossman, but there's another one out there by MacDay, your success rate in re-implantation is going to be anywhere between 70 to 85%. So you might not necessarily get it the second time around when you go in, and if you try a 3rd time, it might drop even further. So that's something to keep in mind when you're re-implanting. This patient here was referred to me by a colleague. He places his own implants and restores his own implants. And you can see that there's significant bone loss. So when I was going in, I pretty much had a good idea that we were looking at an explantation there rather than trying to salvage this implant. But what really convinced me when I went in was the surface that I was dealing with. And if you look at this surface, it's a very, very abrasive, like a very rough surface, and those kinds of surfaces are extremely, extremely difficult to clean. Especially when I look at them under the microscope, I can see all the bits and pieces of particles that are stuck in between this surface coatings, and you can see I've made an attempt, the area that's smooth, I've made an attempt to smooth it down, but it's impossible. So pretty much when I'm seeing a more of a rougher surface, extreme rough surface, these for me are at this point in my experience are out. I don't really have a good way to deal with them. So in this case, the implant was removed and bone grafted, and I sent the patient back to the dentist to go ahead and place a new implant. And when I brought the patient back for a check, I was very upset because I can see where he made his incision line, and as a periodontist, this picture really disturbs me. And I can see that he caused a little bit of recession in that molar on the mesiobuccal. But the implant, again, was successful. The integration took really well. And the patient has been now in function with this reimplanted site for the last 4 or 5 years. So the most important thing is not to try and catch the disease after the fact, but in fact to try and prevent it. I mean, we're all in the business of prevention. We try to prevent caries. We try to prevent relapse of soft tissues when we do extractions. So this is my sort of personal belief that we're better off to head in this direction rather than try and play catch up afterwards. And the interesting fact is that it's not just what the patient is doing, it's very much what you're doing out there, because a lot of the peri-implantitis cases that we're seeing are iatrogenic. And that really bothers me, because we're trying our best for our patients, but if we're causing part of the problem, that becomes very, very significant. And we have to learn how to cut back on the errors that we produce. So many times, you know, we have issues with oral hygiene, and we all have those patients. This is a patient that had this bar placed, comes back 3 months later for his recall, and this is the situation that you see here. So, of course, I mean, at this point, you have to go over oral hygiene and try and get things under better control. This is patient-driven. However, this is not patient-driven. This is dentist-driven. And this is dentist-driven for many reasons. The first reason, if you look at it, you will notice that there is no place the patient can go in there and clean because there is a mask over the inter-implant area that the patient can't even get a floss through. So that's problem number one. However, when you look more closely, problem number two becomes even more significant. You will notice that there is cement underneath the restoration. You will notice that there's an open margin. I don't care how hard you tell that patient to floss or use a proxy brush. There is no way this lady's going to win. She's going to come out a loser here. And she's going to come out a loser because of us. So if you take anything out of this presentation today, is I would really like you to evaluate your cases critically and go back in those areas where there are errors and look at your radiographs extremely, extremely carefully to make sure that none of this takes place. So the first thing you want to do, apart from obviously establish good oral hygiene, is to make sure that your implants are not extremely close together. And I know now with platform switches, we have different studies that tell us that we can bring them a little closer. But in general, once you get bone loss going between two implants that are very close, you have a problem. You have a problem because you can't get in there to disinfect. And you have a problem because the patient can't get in there to disinfect, and the bone disappears really fast, so you can't even graft it because typically it tends to be horizontal bone loss. And the paper here by Tarnow and Wallace looked at this horizontal component of bone loss that happens when two implants are really close together. And there's a newer paper that they've also published, and that paper tells you that perhaps with the platform switches you can bring two implants a little closer together, but again, it becomes a problem if you get an infection. And the last slide that you have on your right is a dentist's wife, believe it or not, that had those implants placed, and she developed peri-implantitis at the crest of the bone. Now, what salvaged me, of course, he is one of my referring dentists, right? So now it's like double the stress because I somehow have to show him that I can deal with this situation. And what really saved me in this instance was that the lady had impeccable oral hygiene. So what ended up happening, we were able to push the tissue a little more apically and treat it almost like a furcation involvement. And she was able to clean and maintain those implants. But this is also iatrogenic. I mean, there is no need for this. Cement. Cement has become my best friend lately because I get to see a lot of it. I see it in all forms. I see it on the buccal. I see it on the interproximal. And it's a problem. It is not the only problem. I know there are many speakers out there that will tell you, oh, it's peri-cementitis, it's not peri-implantitis. I don't agree with that. But I sure see a lot of it out there. There is a very interesting little paper by Dr. Thomas who looked at 34 out of 42 cases that had clinical signs of peri-implantitis. The interesting thing was that he found that 34 out of the 42 had subgingival cement. And when he cleaned out the cement, 74% of them responded positively to that treatment. So cement is definitely something that you really want to be aware of for all of you that do restorative and prosthetic work out there. So this is a patient, this is courtesy of Dr. Hess, who also lectures on cement topics, and he was nice enough to lend me this case, which was very indicative of what can happen to you. And you can see already in this case, you can see the cement. So this is fairly easy because if you can see it, you should be able to remove it. That's not as much of a problem. The cement is visible on the x-ray. You go ahead, you flap it, you remove it, and in all probability, you're going to have a very good outcome. The problem, however, is if you cannot see the cement. There you have an issue, because you don't know that it's there. And if you don't know that it's there, then you have more of a concern. So the way that I would deal with cement, or the recommendations that I have, and I've spoken to fellow colleagues that are in the prosthodontic field, would be definitely to look at custom abutments, to try and look at screw-retained restorations when your preparation is going to be really deep subgingivally, and you feel you don't have a good handle on going there and removing the excess cement. Using radiopaque cement. I've heard that Tembond is quite radiopaque and might have some good characteristics. I know that I can remove Tembond easily, as opposed to the glass ionomer cements where I've flapped it and I'm in there hammering at the cement and it's fused to the threads or fused to the platform and I can't get it out. Retraction cord at the time of cementation. I have seen plumber's tape. I've seen some restorative dentists use plumber's tape. You put it in the sulcus, and as you pull the plumber's tape out after you've cemented it in, the cement comes out in one piece, which is nice. You don't get the pieces that get stuck on the cord. And venting the abutment, which I thought was a very interesting idea, and I think there are some studies that have been done that show that that can be useful. You literally make holes into your abutment so the cement goes into the abutment as opposed to extruding out. So that might be another useful tool in your cementation process. This is a case that we treated at the university. Patient came in, had her implant placed, and was referred downstairs to our undergraduate department to have her crown done. And unfortunately, as it is with universities, you know, it's two different departments. She goes down. By the time her work is done, we don't see her for a little while. She comes back, and we're starting to notice bone loss around her implant. And again, being a university setting, doesn't really get treated on a timely basis. And unfortunately, what ends up happening, she ends up losing her implant. But what I thought was more significant here was about the cement you cannot see, which what I told you earlier. You cannot see the cement, but it's there, and it caused the failure of this implant. So again, you know, be aware of it. If you don't see it on the x-ray, doesn't mean it's not there. But look at the response of the soft tissues, because the soft tissues will always tell you what's going on. So if you're seeing a mucositis reaction, if you're seeing an inflammation, if you're seeing deepening of the clinical probing depths, that should really give you a clue that there is something in there that should be looked after. Chronic periodontitis patients. You know, that there is some evidence now that's coming out in the literature more and more that your patients that are in your practice that have periodontal disease are not well controlled are at much higher risk of developing peri-implantitis compared to the ones that don't have any, that are, for example, congenitally missing laterals. So be aware of those patients, think of them as a higher risk group, bring them in for more frequent recalls, pick up your periodontal probe, and be active in terms of looking around your restorations and make sure that the tissues are healthy, and have records in your chart so that you can have something to compare to. This is a patient that I treated, so as I said, I learned from others' mistakes, but I also learned from mine. This lady had generalized chronic severe periodontitis. She was a smoker, and she came to the office, and she wanted desperately to have implants on the top right-hand side because she was missing teeth, and she felt that was affecting her ability to chew and her aesthetics. And at the time, being a rookie, I thought, okay, yes, we'll go ahead, we'll put the implants in. When I had put the implants in, the lady didn't come back for any periodontal maintenance. It's as if she forgot. We called over and over again, wasn't really interested. What happened is her periodontal condition worsened. She was smoking about a pack of cigarettes a day. And when she eventually did come in for her recall, we had already gotten started on the path to peri-implantitis with bone loss around her implants and increased probing depths. So as a cautionary tale, really make the patient aware when they have chronic periodontitis problems to really be on top of it, and explain to them that if they don't, you'll be seeing them 5 to 6 years later, very likely with problems. And that it is not a solution that we're putting implants in those chronic periodontitis patients and they'll be there forever, because they will not. You will have issues with them. And the last little tip on prevention is you want to make sure you have a nice abutment connection. And I see Tord is in the room, so that is his paper that he published. And if you have an abutment connection that doesn't wobble, that doesn't have fluid in it with bacteria, that can have a seal with no bacteria in it, you're at an advantage, because that is an area that, again, will stay disinfected or clean. And you can see here that Tord did a study where he placed implants in a microbial broth and saw which ones were leaking inside the implant. And so a conical connection is a very nice connection to have for long-term stability. So are we almost done? Okay. So the last 2 points that I'm going to give you is what to do for your in-office maintenance. And you need to follow your patients on a regular basis and make sure that you record everything, your radiographs, clinical probing depths, and make sure that there's no changes. Because what can happen is it can creep up on you, just like this patient case, which is the last case that I'll be showing you. This patient started developing peri-implantitis, and unfortunately, we had to explant and start over again for her. So I'm hoping that you will not get to that point, and I'm hoping that you will be able to pick up the case early and treat it in an earlier manner. Thank you very much for your kind attention.
Thank you very much. Thank you.